Hello everyone and good afternoon. We are the group 5 and we're going to be talking about anticoagulants and antiplatelet agents. So anticoagulants and antiplatelet drugs are the two classes of antithrombic drugs. Anticoagulants slow down clotting, thereby reducing fibrin formation. Antiplatelet agents prevent platelets from clumping, and just like anticoagulants, they prevent clots from forming and growing. So kani silang mga drugs kay useful sa pag-treat sa mga disorders of hemostasis. Hemostasis is the normal response of the vessel to injury which stops bleeding, forming a clot that serves to limit hemorrhage. Thrombosis, the formation of an unwanted clot within a blood vessel, is the most common abnormality of hemostasis. Examples atong mga thrombotic disorders include acute myocardial infarction, deep vein thrombosis or DVT, pulmonary embolism, and acute ischemic stroke. Atong mga bleeding disorders which relate to failure of hemostasis kay less common sila than our thromboembolic disorders. And bleeding disorders include hemophilia, which is treated with transfusion of recombinant factor 8, and vitamin K deficiency, which is treated with vitamin K supplementation. So these will be the drugs that we're going to talk about. We're going to discuss first platelet inhibitors, followed by anticoagulants, then thrombolytic agents, and lastly drugs we use for the treatment of bleeding. But before we discuss the drugs in detail, let's quickly review the clotting process. So in the absence of injury, the endothelial cells that make up the inner surface of blood vessels release chemical mediators such as nitric oxide and prostacyclin. Nitric oxide's job is to dilate blood vessels, while prostacyclin's job is to bind to receptors located on platelets. This binding triggers certain reactions which ultimately prevent platelet activation and aggregation. When there is damaged blood vessel, for instance, kung atong nakatang atong self, we have less nitric oxide and prostacyclin around, so blood vessels become constricted and platelets become activated. But first things first, with the help of von Willebrand factors, platelets adhere to exposed collagen, which in turn causes them to change shape. Next is that these activated differently shaped platelets begin to release granules containing chemical mediators such as atong ADP, thrombin, thromboxane A2, serotonin, and platelet activating factor, which attract and activate even more platelets that come to the site of injury. The final step involves activation of glycoprotein 2b3a receptors which bind to circulating fibrinogen. Kaning fibrinogen kay simultaneously bind to these receptors on two separate platelets, thus cross-linking platelets to form aggregates. Now let's talk about our platelet inhibitors or simply our antiplatelet drugs. One of the most widely known drugs that belong to this class is aspirin. So in order to understand how aspirin works, let's take a closer look at the inside of a platelet. So when the platelet becomes activated, arachidonic acid na ma-release from its membrane phospholipids. Then, ma-convert ni siya into prostaglandin H2 by cyclooxygenase 1 enzyme. Finally, prostaglandin H2 is further metabolized to thromboxane A2, which is released from the platelet to stimulate the activation of new platelets as well as to promote their aggregation. Ang ginabuhat sa aspirin is that it irreversibly inactivates COX-1 enzyme, thus effectively disrupting clot formation. In other words, the inhibition of platelet aggregation by aspirin occurs because of its interference with the thromboxane A2 in the platelets, caused by COX-1 inhibition. Thromboxane A2 is an important lipid responsible for platelet aggregation, which can lead to clot formation and future risk of heart attack or stroke. So aspirin is used in the prophylactic treatment of transient cerebral ischemia, stroke that lasts only a few minutes. It is also used to reduce the incidence of recurrent myocardial infarction and to decrease mortality in the setting of primary and secondary prevention of MI. Complete inactivation of platelets occur with 75 milligrams of aspirin given daily. Aspirin is quickly hydrolyzed to salicylic acid in the liver, and salicylic acid is further metabolized in the liver, and some is excreted and changed in the urine. The half-life of aspirin ranges from 15 to 20 minutes, and for salicylic acid it is 3 to 12 hours. Higher doses of aspirin increase drug-related toxicities, as well as the probability that aspirin may also inhibit prostacyclin production. Bleeding time is prolonged by aspirin treatment, causing complications that include an increase of incidence of hemorrhagic stroke and gastrointestinal bleeding. Nonsteroidal anti-inflammatory drugs such as ibuprofen inhibit COX-1 by transiently competing at the catalytic site. Ibuprofen, if taken within 2 hours prior to aspirin, can obstruct the access of aspirin to the serine residue, and thereby antagonizing platelet inhibition by aspirin. Therefore, kung plano nato mag-take og intermediate release na aspirin, it should be taken at least 60 minutes before or at least 8 hours after ibuprofen. Next, we have platelet aggregation inhibitors that work by blocking the action of ADP receptor, specifically P2Y12 subtype. So drugs that belong to this group include clopidogrel, ticagrelor, ticlopidine, and prasugrel. And as I mentioned before, activated platelets release chemical mediators, and one of them is ADP, which binds to P2Y12 receptor, leading to activation of the glycoprotein 2B3A receptors, which are required for fibrin-mediated platelet cross-linking. So by blocking P2Y12 ADP receptors, these drugs effectively inhibit platelet aggregation and thus clot formation. We have to note that ADP receptor inhibitors are administered orally sila, with the exception of cangrelor. Furthermore, the other agents require oral loading doses for quicker antiplatelet effect. And since cangrelor, being administered IV, has a fast onset of action, it does not require a loading dose. So clopidogrel is approved for the prevention of atherosclerotic events in patients with recent myocardial infarction or stroke, and in those with established peripheral arterial disease. It is also approved for the prophylaxis of thrombotic events in acute coronary syndromes. Additionally, clopidogrel is used to prevent thrombotic events associated with precutaneous coronary intervention, with or without coronary stenting. Clopidogrel is a prodrug, and EM therapeutic efficacy relies on its active metabolite, which is produced via the metabolism by CYP2C19. Genetic polymorphism of CYP2C19 leads to a reduced clinical response in patients who are poor metabolizers of clopidogrel. Tests are currently available to identify poor metabolizers, and it is recommended that the other antiplatelet agents such as prasugrel or ticagrelor be prescribed for these patients. In addition, other drugs that inhibit CYP2C19, such as omeprazole and esomeprazole, should be avoided while on clopidogrel. After a single oral dose of 75 milligrams, clopidogrel has a half-life of approximately 6 hours. Ticlopidine, on the other hand, has a similar structure to clopidogrel. It is indicated for the prevention of transient ischemic attacks and strokes in patients with prior cerebral thrombotic events. However, due to life-threatening hematologic adverse reactions, ticlopidine is generally reserved for patients who are intolerant to other therapies. Food interferes with the absorption of ticlopidine, but not with the other agents. Half-life following a single 250 milligram dose is approximately 7.9 hours in subjects 20 to 43 years of age. Ticlopidine is associated with severe hematologic reactions that limit its use, such as agranulocytosis, or when there is an extremely low number of granulocytes, a type of white blood cells, TTP, and aplastic anemia, or when the bone marrow cannot make enough new blood cells for our body to work normally. And now we have cangrelor, which is the only P2Y12 platelet receptor antagonist that is administered IV. It is used during percutaneous coronary intervention, also known as angioplasty with stent, a non-surgical procedure that uses a catheter, a thin flexible tube, to place a small structure called a stent to open up blood vessels. So cangrelor is used to reduce the risk of periprocedural myocardial infarction, repeat coronary revascularization, and stent thrombosis. The average elimination half-life of cangrelor is about 3 to 6 minutes, and the common adverse effects of this drug includes pain in the stomach and the back, as well as coughing up blood and joint pain. Next, we have prasugrel, and it is approved to decrease thrombotic cardiovascular events in patients with acute coronary syndromes. Its active metabolite has an elimination half-life of about 7.4 hours, and it is contraindicated in patients with a history of transient ischemic attack or stroke, and it possesses warnings for bleeding. Next, we have ticagrelor, which is approved for the prevention of arterial thromboembolism in patients with unstable angina and acute myocardial infarction, including those undergoing percutaneous coronary intervention. Unlike clopidogrel, ticagrelor is not a prodrug, and common adverse effects of this drug include getting out of breath and bleeding more easily than normal. You may have nosebleeds, heavier periods, bleeding gums, and bruising. You can drink alcohol with ticagrelor. And next we have glycoprotein 2b3A receptor blockers, namely abscimab, eptifibatide, and tirofiban. These agents simply inhibit platelet aggregation by binding to the glycoprotein 2b3A receptors and platelet, thus preventing fibrinogen from binding to platelets and making them unable to cross-link, unlike the other drugs that we have discussed so far. So we have to remember nga kaning mga glycoprotein 2b3A inhibitors are administered intravenously lang sila. Furthermore, these agents are given along with heparin and aspirin as an adjunct to PCI for the prevention of cardiac ischemic complications. So let's first talk about abscimab. It is also approved for patients with unstable angina not responding to conventional medical therapy when PCI is planned within 24 hours. Abscimab is given by IV bolus, followed by IV infusion, achieving peak platelet inhibition within 30 minutes. The metabolism of abscimab is unknown, and after cessation of abscimab infusion, platelet function gradually returns to normal, with the antiplatelet effect persisting for 24 to 48 hours. Next, we have the two drugs, eptifibatide and tirofiban. So when IV infusion of eptifibatide or tirofiban is stopped, both agents are rapidly cleared from the plasma. Eptifibatide and its metabolites are excreted by the kidney, and tirofiban is excreted largely unchanged by the kidney, and to a lesser extent in the feces. Plasma elimination half-life is approximately 2.5 hours for eptifibatide, and tirofiban, on the other hand, has a half-life of approximately 2 hours. The major adverse effects of these agents is bleeding, especially if used with anticoagulants, which we will discuss more in detail later in this presentation.
Now the last group of antiplatelet drugs that we wanted to briefly discuss are phosphodiesterase inhibitors, namely dipyridamole and cilostazol. These two agents inhibit enzyme called phosphodiesterase that is responsible for breaking down cyclic AMP to AMP. So by blocking this enzyme, dipyridamole and cilostazol increase intracellular levels of cyclic AMP, which in turn leads to decrease in intracellular calcium and ultimately inhibition of platelet activation. Furthermore, these agents inhibit phosphodiesterase in the vascular wall as well as uptake of adenosine, which promotes vasodilation. For that reason, cilostazol in particular is often used to treat symptoms of peripheral artery disease such as narrowing of vessels that supply blood to legs. Dipyridamole and cilostazol, due to their vasodilating properties, can produce headaches.
For the dipridamole and its brand name Presentin, this agent is given orally to prevent dangerous blood clots from forming. It is also used to lessen the chance of stroke or other serious medical problems when a blood vessel is blocked by blood clots. Dipridamole has variable bioavailability following oral administration. It is highly protein-bound. The drug undergoes hepatic metabolism, mainly glucuronidation, and is secreted primarily in the feces, although enterohepatic circulation can occur. The average time to peak concentration is about 75 minutes. The alpha half-life, or the initial decline following peak concentration, is approximately 40 minutes. The beta half-life, or the terminal decline in the plasma concentration, is approximately 10 hours. It is metabolized in the liver, where it is conjugated as a glucuronide and excreted with the bile. For the adverse effect, patients with unstable angina should not use the dipyridamole because of its vasodilating properties, which may worsen ischemic coronary steal phenomenon. Dipyridamole commonly causes headache and dizziness and can lead to orthostatic hypotension, especially if administered IV. For the silostazole, this agent is given orally. It is used to reduce leg pain caused by poor circulation, intermittent claudication. This medicine works by keeping blood from clotting and by dilating or relaxing the blood vessels. Xylostazole is extensively metabolized in the liver by the CYP3A4 and 2C19 isoenzymes. Xylostazole and its active metabolites have apparent elimination half-lives of about 11 to 13 hours. Xylostazole is highly protein-bound. It is largely excreted by the kidneys 74% and less so by the liver 20%. Headache and GL side effects, such as diarrhea, abnormal stools, dyspepsia, and abdominal pain are the most common adverse effects observed with xylostazole. As such, xylostazole is contraindicated in the patients with heart failure. For the blood coagulation, the coagulation process that generates thrombin consists of two interrelated pathways, the extrinsic and the intrinsic systems. The extrinsic system is initiated by the activation of clotting factor 7 by tissue factor also known as thromboplastin. The intrinsic system is triggered by the activation of clotting factor 12. This occurs when blood comes into contact with the collagen in the damaged wall of a blood vessel. It is important that coagulation is restricted to the local site of vascular injury. Endogenously, protein C, protein S, and thiothrombin 3 and tissue factor pathway inhibitor all inhibit coagulation factors. The mechanism of action of several anticoagulant agents, including heparin and heparin-related products, involves activation of these endogenous inhibitors, primarily antithrombin 3. Heparin is an injectable, rapidly acting anticoagulant that is often used acutely to interfere with the formation of thrombi. Heparin occurs naturally as a macromolecule complex with histamine in mast cells, where its physiologic role is unknown. These agents are used for the treatment of acute venous thromboembolism. Heparin and low molecular weight heparins are also used for prophylaxis of postoperative venous thrombosis in patients undergoing surgery and those with acute MI. These drugs are the anticoagulants of choice for treating pregnant women because they do not cross the placenta due to their large size and negative charge. Heparin must be administered subcutaneously or intravenously because the drug does not readily cross membranes. Heparin is often initiated as an intravenous bolus to achieve immediate anticoagulation. In the blood, heparin binds to many proteins that neutralize its activity, causing unpredictable pharmacokinetics. Heparin binding to plasma proteins is variable in patients with thromboembolic disease. The half-life of heparin is approximately 1.5 hours, whereas the half-life of the low molecular weight heparins is longer than the of heparin, ranging from 3 to 12 hours. Possible adverse effects reaction includes chill, fever, urticaria, and anaphylactic shock. Heparin and low molecular weight heparins are contraindicated in patients who have hypersensitivity to heparin, bleeding disorders, alcoholism, or who had recent surgery of the brain, eye, or spinal cord. Argatroban is used for the prophylaxis or treatment of venous thromboembolism in patients with HIT, and it is also approved for use during percutaneous coronary intervention in patients who have or are at risk for developing HIT. Anticoagulant effects are immediate. Argatroban is metabolized in the liver and has a half-life of about 39 to 51 minutes. As with other anticoagulants, the major side effect is bleeding.
So good day everyone. Let's now proceed with bivalirudine and deciridine. So bivalirudine and deciridine, they are parenteral anticoagulants that are analogs of hirodine. So for the information of everybody, Hiridine, it is a thrombin inhibitor, and it is derived from the saliva of a medicinal leech. So these drugs, this bivilaridine and disiridine, they are selective direct thrombin inhibitors, and they reversibly inhibit the catalytic site of both free and clot-bound thrombin. So first with bivalirudin. So bivalirudin, it is an alternative to heparin in patients undergoing a PCI or precutaneous coronary intervention who have or are at risk for developing HIT or heparin-induced thrombocytopenia. And also bivalirudin, it is an alternative to heparin in patients with unstable angina undergoing angioplasty. So in patients with normal renal function naman, the half-life of bivalirudin is 25 minutes, and usually dosage adjustments are required in patients with renal impairment. So on the other hand, the Cyrudine, it is indicated for the prevention of DVT or deep vein thrombosis, especially in patients undergoing hip replacement surgery. And like the others, no, bleeding is the major side effect or significant side effect of these agents. So next drug is fondaparinux. So fondaparinux, it is a synthetically derived pentasaccharide anticoagulant that selectively inhibits the factor XA. So by selectively binding to antithrombin 3, fondaparinux they potentiates the innate neutralization of factor XA by antithrombin 3. So, fondaparinux, it is approved for use in the treatment of DVT or deep vein thrombosis and PE or pulmonary embolism. And also, it is approved for the treatment of prophylaxis and venous thromboembolism in the setting of the orthopedic and abdominal surgery. So this drug, it is also well absorbed from the subcutaneous route with a predictable pharmacokinetic profile and therefore require less monitoring than heparin. So in terms of elimination, fondaparinux, it is eliminated in the urine mainly as unchanged drug with an elimination half-life of 17 to 21 hours. So it is contraindicated in patients with severe renal impairment. And also, bleeding is the major side effect of fondaparinux, and sadly, there is no available agent for the reversal of bleeding associated with this drug. HIT or heparin-induced thrombocytopenia, it's less likely to form with fondaparinux than with heparin, but it is still a possibility. So at this juncture, let's now proceed with vitamin K antagonist. So, vitamin K antagonists are also known as coumarin anticoagulants. So, they inhibit the release of plasma clotting factor 7 by vitamin K, and they owe their action to the ability to antagonize the cofactor functions of vitamin K. Also, the only coumarin anticoagulant available in the United States is warfarin. We also have this international normalized ratio or an INR, which is the standard by which the anticoagulant activity of warfarin therapy is monitored. So warfarin, it has a narrow therapeutic index, therefore, it is important that the INR is maintained with the optimal range as much as possible, and frequent monitoring may be required. So now let's discuss the warfarin. So for its mechanism of action, warfarin, it is an inhibitor of vitamin K reductase. So what it does is that it binds to the enzyme which is the vitamin K reductase in the liver cells, and consequently it inhibits its activity, resulting in the decreased production of reduced form of vitamin K. Then it leads to the deactivation of gamma glutamyl carboxylase, and consequently it impairs the conversion of glutamic acid to the to gamma carboxylic glutamic acid, which in turn causes its decrease also. So this decrease in gamma carboxylic glutamic acid, it suppresses the production of clotting factors that contain the GLA proteins such as factors 2, factor 7, factor 9, factor 10, also with protein C and protein S. So the warfarin treatment, it results in the production of clotting factors with diminished activity due to the lack of sufficient gamma carboxyglutamyl side chains. So unlike heparin, no, the anticoagulant effects of warfarin, they are not observed immediately after drug administration. Instead, peak effects may be delayed for 72 to 96 hours, which is the time required to deplete the pool of circulating clotting factors. So the anticoagulant effects of warfarin, it can be overcome by the administration of vitamin K. However, reversal following administration of vitamin K takes approximately 24 hours. So let's now discuss the therapeutic uses of warfarin. So warfarin, it is used in the prevention and treatment of deep vein thrombosis or DVT and PE or pulmonary embolism. Also, it is used for the stroke prevention in the setting of atrial fibrillation and for the prosthetic heart valves. Protein C and S deficiency, also for antiphospholipid syndrome. So it is also used for the prevention of venous thromboembolism following orthopedic surgery. So warfarin, it is rapidly absorbed after oral administration. So it has a 100% bioavailability with little individual patient variation. So warfarin, it is highly bound to plasma albumin, which prevents its diffusion into the cerebrospinal fluid, urine, and breast milk. However, drugs that have a greater affinity for albumin binding sites, such as sulfonamides, can displace the anticoagulant and lead to transient elevated activity. So, warfarin, it readily crosses the placental barrier. This means half-life of warfarin is approximately 4 hours, but this value is highly variable among individuals. So, warfarin is also metabolized by CYP450 system to inactive components. So, after conjugation to glucuronic acid, the inactive metabolites, they are excreted in urine and feces. So, agents that affect metabolism of warfarin, it may also alter its therapeutic effects. So the principal adverse effect of warfarin is bleeding. So minor bleeding, it may be treated by the withdrawal of the drug or administration of oral vitamin K, but severe bleeding, it may require greater doses of vitamin K, which is given intravenously. So aside from that, skin lesions and necrosis are rare complications of warfarin therapy. Also, purple toe syndrome, it also has been observed with warfarin therapy. And lastly, warfarin is teratogenic and it is contraindicated in pregnancy. So at this juncture, let's discuss the direct oral anticoagulants. So the first drug under this classification is the bigatran. The bigatran is actually the active moiety of the prodrug, the bigatran etexylate. So the bigatran etexylate, it is the prodrug, and the bigatran, it is the active metabolite. So the bigatran, it is an oral direct thrombin inhibitor, and it inhibits both clot-bound thrombin and free thrombin. So the bigatran, it is approved for the prevention of stroke and systemic embolism in patients with non-valvular atrial fibrillation. It may also be used in the treatment of DVT and PE. So this drug, it is contraindicated in patients with mechanical prosthetic heart valves, and it is not recommended in patients with bioprosthetic heart valves. So the bigatran etixylate, which is the prodrug, it is administered orally. It is then hydrolyzed to the active drug or the which is the bigatran by various plasma esterases. So it is a substrate for P-glycoprotein and it is eliminated orally. Like other anticoagulants, the major adverse effect of this dabigatran is bleeding. So this should be used with caution in renal impairment or in patients over the age of 75, as the risk of bleeding is higher in these groups. So we have idarucizumab, which is used to reverse the bleeding in severe cases. So GI adverse effects are also common with the bigatran and may include dyspepsia, abdominal pain, esophagitis, and GI bleeding. Drug discontinuation should also be avoided as patients may be at increased risk for thrombotic events. Let's now proceed to the direct oral factor XA inhibitors. So drugs included in this drug type is apixaban, betrixaban, edoxaban, and rivaroxaban. They are oral inhibitors of factor XA, and they work by inhibiting the factor XA, which reduces the production of thrombin and prothrombin. So with the exception of betrixaban, these agents, they are approved for the prevention of stroke in non-valvular atrial fibrillation, as well as the treatment of DVT and PE. So rivaroxaban and apixaban, they are also used as prophylaxis to prevent or reduce the risk of recurrence of DVT and PE. Betrixaban, on the other hand, is indicated for the prophylaxis of DVT and PE in at-risk hospitalized medical patients. So direct oral factor XA inhibitors, these drugs they are adequately absorbed after oral administration. Rivaroxaban, it is metabolized by the CYP3A4 or 5 and CYP2J2 isoenzymes to inactive metabolites, and about one-third of the drug is excreted unchanged in the urine. Apixaban, on the other hand, it is primarily metabolized by CYP3A4 with CYP enzymes 1A2, 2CA, 2C9, 2C19, and 2J2, and all of them sharing minor metabolic roles, and approximately 27% is excreted renally. So we also have edoxaban and metrixaban, which are minimally metabolized and are eliminated primarily unchanged in the urine and feces, respectively. Concomitant administration of apixaban and rivaroxaban with drugs that are strong PGP and CYP3A4 inducers should be avoided due to the potential for reduced efficacy of the factor XA inhibitors. So for the adverse effects, so bleeding is the most serious adverse effect. Currently, there is no antidote, but recombinant factor XA products are in development. So declining kidney function can prolong the effect of these drugs and therefore increase in the risk of bleeding. That's why renal dosage adjustments are recommended for these agents. Also, abrupt discontinuation of the factor XA inhibitor should also be avoided.
So next up are thrombolytic drugs. Thrombolytic treatment is also known as fibrinolytic or thrombolysis, and thrombolytics are medicines that may be used for the emergency treatment of an ischemic stroke, a heart attack, or a massive pulmonary embolism. And these drugs are plasminogen activators, wherein they convert plasminogen into the active natural fibrinolytic agent plasmin, and this plasmin is derived from plasminogen, an inert protein precursor that can be activated by tissue plasminogen activator or TPA, and it is present in blood that degrades many blood plasma proteins including fibrin clots. And these fibrin are the insoluble protein that is formed from fibrinogen produced in response to bleeding, and it is also essential for blood clot contraction, that is spontaneous shrinkage of the clot, which plays a role in hemostasis and wound healing. And several lifestyle factors can also increase your fibrinogen levels, including smoking, eating a meat-heavy or high-carb diet, and vitamin B6 and iron deficiency. And in addition to its binding and activation of fibrin clots, PLG or plasminogen also specifically interacts with cell surfaces where it is more efficiently activated by plasminogen activators compared with the reaction in the solution. And you can see it in the diagram. For plasminogen to be converted to its active form, plasmin, it needs thrombolytic drugs which will stimulate the activity, and the natural fibrinolytic agent plasmin will later break down the blood clot, allows free flow of blood to the affected areas, and supplies oxygen and nutrients, limiting the damage. So, ischemic stroke occurs when an artery that supplies blood to the brain is blocked by a blood clot or a fatty buildup called plaque. And while a heart attack or myocardial infarction happens when one or more areas of the heart muscle don't get enough oxygen. And this occurs because the plaque with acute clot in the coronary artery is blocking the blood flow and oxygen to the heart. And these thrombolytic drugs or thrombolytics work effectively if given immediately after the event and as close as possible to the site of the blood clot. And these drugs may be given within 3 hours post onset of the symptoms of a stroke and within 12 to 24 hours post onset of the symptoms of a heart attack. Now, what are the risks or complications of thrombolytic therapy? So as with anticoagulants, hemorrhage or bleeding is the primary adverse effect associated with thrombolytic therapy. and this occurs when small pieces of blood clot break off and travel deeper into the affected organ. Bleeding may occur from your intravenous puncture, wounds, or other recent injury sites, and more than 70% of bleeding episodes occur at vascular puncture sites. So this is why invasive procedures should be minimized as much as possible in thrombolytic therapies. However, the incidence can be reduced by careful selection of the patients and avoidance of unnecessary invasive procedures. So there are three types of bleeding. First is the internal bleeding, or the bleeding that occurs inside the body when a blood vessel is damaged. The most common type of visible internal bleeding is a bruise, when blood from damaged blood vessels leaks into the surrounding skin. We also have the superficial bleeding, which usually does not bleed excessively and can appear to close. And the most devastating complication associated with systemic thrombolytic therapy is the development of intracranial bleeding, which occurs in less than 1% of patients. So in intracranial bleeding, the pooling of blood puts pressure on the brain, which can lead to rapid brain damage or death. And intracranial bleeding are life-threatening medical emergencies that require immediate treatment. And intracranial bleeding has subtypes, which are the intracerebral bleeding, which consists of intraventricular bleeding and intraparenchymal bleeding. We also have the subarachnoid bleeding, epidural bleeding, and subdural bleeding. Other adverse effects of thrombolytic drugs include nausea, vomiting, hypotension, as well as anaphylactic reactions. First thrombolytic drug on the list is alteplase. So, isa ni siya ka tissue plasminogen activator or TPA, and it is usually given within 3 hours after the first signs of stroke or a heart attack symptom. And according sa na-research nako, ang treatment daw with alteplase was beneficial for a delay in treatment extending to 4.5 hours after stroke onset, with a greater benefit with earlier treatment. And neither age nor stroke severity significantly influence the slope of the relationship between the benefit and time to treatment initiation. However, alteplase increases your risk of bleeding, which can be severe or fatal. Since it is given as an infusion into a vein, bleeding may occur from a surgical incision or gikan sa skin kung saan gi-insert ang needle during a blood test or while receiving the injectable medication. And taking this drug means na dapat makabalo ka sa possible side effects that it may induce, katulad ng headache, nosebleed, and hemoptysis or kanang pag-ubo na naay kauban na dugo. And alteplase is ginabawal siya sa mga patients who are currently taking aspirin or ibuprofen, patients who have active internal bleeding, severe uncontrolled hypertension, and bleeding diathesis, or patients na may increased tendency to bleed or bruise. Next is tenecteplase. Tenecteplase is a third-generation multiple-point mutant of alteplase. Tenecteplase has a half-life of 20 minutes and is given by a single bolus injection. So tenecteplase is the most fibrin-specific thrombolytic drug approved for clinical use. Similar with alteplase, it can also increase the risk of your bleeding, especially sa part ng skin kung saan gi-insert ang needle during intravenous administration. For the recommended total dose, it should not exceed 50 milligrams, and it is based upon the patient weight. And a single bolus dose should be administered over 5 seconds based on the patient weight. Treatment should be initiated as soon as possible after the onset of acute myocardial infarction symptoms. Since ang dose natin for this drug is nakadepende sa weight ng patient, we have to refer for the dosing indicated in this table above of the slide. Like, if less than 60 kilograms a patient, the dosage would be 60 milligrams or 6 ml of its volume to be administered. Then, sa warnings and precautions regarding this drug is similar lang sa Altiplase, no? Katulad din ng ibang mga gamot or activities that the patient should avoid before and while receiving this medication, pati na rin yung kasabay na side effects and other drug information. The next subtopic I am going to discuss is about the drugs in the treatment for bleeding. But before that, I need natin malaman kung bakit nagkakaroon ng bleeding problems. A bleeding disorder is a health problem that makes it difficult for a person to stop bleeding. Normally, when a person is hurt, a blood clot forms to stop the bleeding quickly. For blood to clot, your body needs a type of cell called platelets and blood proteins called clotting factors. Kapag may bleeding disorder ka, it means that your platelets or clotting factors are either not functioning well or your body does not make enough of it kaya nagkakaroon ng deficiency. And bleeding disorders affect both women and men. But bleeding disorders can cause more problems for women as this makes it easy for too much bleeding to happen during normal bodily functions such as their menstrual period. Usually, bleeding disorders are inherited, such as hemophilia, passed down from parent to child when you are born. But it is also possible to have bleeding disorder even if your parents did not. Sometimes, bleeding disorders can be caused by other health problems or the medicines that you take. So these are the other causes of bleeding problems, which includes liver disease. This is because your liver makes most of blood clotting factors, which are also proteins in the blood that you need. Second is kidney disease, especially in the advanced stages. Next is side effects from certain medications such as blood thinners or anticoagulants, certain pain medicines or the analgesics or the long-term use of antibiotics. And lastly is thyroid hormone imbalance. The first two drugs of choice for the treatment of bleeding are the plasminogen activator inhibitors, like the aminocaproic acid sold under the brand name Amicar and tranexamic acid sold under the brand names cyclopentone and Listada. These medications are used for bleeding as to control fibrinolytic states. When we say fibrinolytic state, it comes from the word fibrinolysis, which refers to the process that prevents blood clots from growing and becoming problematic. Because it breaks down unwanted fibrin deposits, blood flow is improved and it doesn't help in the management of bleeding disorder. So these drugs can lead to following side effects such as muscle necrosis, CVA, seizure, and intravascular thrombosis. And they are synthetic, orally active, and excreted in the urine, and it says that tranexamic acid is 10 times more potent than aminocaproic acid. Second is protamine sulfate. So protamine sulfate is to treat bleeding by reversing the effects of heparin. Heparin is an anticoagulant, so it keeps blood clots from forming, thus it can lead to coagulation disorders, which can cause excessive bleeding if the body is unable to form blood clots properly. This makes it possible when the positively charged protamine sulfate interacts with the negatively charged heparin and it creates a stable complex without any anticoagulant activity. However, protamine sulfate can lead to side effects such as flushing, nausea, bradyarrhythmia, hypotension, anaphylaxis, and dyspnea or the shortness of breath. Vitamin K1, or also known as phytonadione, which is sold under the brand name Mephyton, and vitamin K1 is used to treat patients who have bleeding problems due to the effects of warfarin. So similar to heparin, warfarin is also an anticoagulant which can lead to coagulation disorders, thus causing excessive bleeding. It can cause side effects such as skin reactions and anaphylaxis. So when we ask how long does it take for vitamin K1 to reverse the effects of warfarin, so prothrombin complex concentrate administration will reverse the anticoagulation within minutes of administration, while the FFP or the fresh frozen plasma administration can take hours due to the volume required. Vitamin K1 effects takes 12 to 24 hours, but administration of vitamin K1 is needed to counteract the long half-life of warfarin. For the last drug for the treatment of bleeding problem included in this slide is idarucizumab, a monoclonal antibody fragment sold under the brand name Praxbind. So similar lang siya og mechanism of action sa last two drugs. However, gikan sa dabigatran, iyang gina-reverse na anticoagulant effects. And by binding to dabigatran and its metabolites, idarucizumab neutralizes anticoagulation. Idarucizumab is administered intravenously and it is rapidly eliminated, and it is also used in emergency situations like in the inpatient setting, and using idarucizumab can cause side effects such as hypokalemia and thrombosis. And I think that would be all in our presentation from Group 5 all about anticoagulants and antiplatelet agents. Thank you for giving us your attention and listening to our report.